Good evening all. As you may or may not be aware, there was an article that appeared in RC Psych Insight from Dr. Hilary Cass, the OBE, who is the head of the Cass investigation, which is currently being taken out in regards to the problem of gender dysphoria, so-called gender dysphoria, in children, and exactly what will be the new provision that will be coming into fruition in the next few years. What we have is an article called Changing the Conversation around the heading Gender Identity. And there's a nice picture of Hillary, right? Okay, so let me say that, first of all, I think that Hilary Cass has been given an impossible job. And my primary concern has always been, as I'm sure those of you who watch my channel regularly, the very narrow and limited sphere in which Hilary has to work. I would say that this article, which is not just an article, but an article and then two differing opinions, which I'll go through with you, are indicative of a very complex, very contested, and very hard field to navigate. And my thanks to Hilary for even sticking around to do so, because I don't think many of us would, quite frankly. However, having said that, I am less than happy with what this article has to say, but the caveat being, I can get pissed off about a boiled egg, right? So the caveat being, okay, that I am no expert, I just read what's written on the page and take what I can from it. And also we still have to wait, as Dennis has reminded me, and Clive has reminded me, for the final report. So let's dig in, shall we, and see what's being said. First of all, Cass talks about, I'm not going to go into great depths about this bit, about the work she's done in the past and how difficult some of it was, which is very important in giving, if you will, a narrative resonance to the situation she's currently finding herself in, and then goes on to say, through my independent review of gender identity services for children and young people, I am encountering echoes of these challenges. The challenges she's talking about, the ones earlier in her career that proved very challenging, which are interfering with our ability to provide holistic, person-centered services for young people. Now, she's saying young people here. I do wish she'd say children. I do wish she would. Across the NHS, we have inadvertently othered young people with gender dysphoria, so that many of them are on a distressingly long waiting list to be seen at the Gender Identity Development Service at Tavistock and Portman. The words othered are in speech marks. That worries me greatly. The use of that language is the language of critical social justice. That worries me greatly. And also to say othered young people with gender dysphoria, so that many of them are on a distressingly long waiting list. There is absolutely no evidence to say these people have gender dysphoria. None. Because there is no evidence for gender dysphoria. What we are talking about is children in distress. Thankfully, Cass goes on in that tenor. She then continues, and we have not had co-occurring developmental, psychosocial, or mental health problems addressed locally. So there was a pull, by the sound of this, to a centralisation that was going on, as we'll see as Cass continues. If we are to serve them better, we need to understand why this is the case. The case being that they didn't get the mental health problems they had addressed, because this gender dysphoria, or gender distress, whatever you want to call it, is a symptom, not a cause. So it's usually a symptom of something else, as we know. Could be autism, could be ADHD, could be abusive backgrounds, could be anything, okay? So if we are to serve them better, we need to understand why this is the case, have more open discussions about the barriers to good care, and work together across professional, societal, and cultural divisions to find solutions. I deeply disagree with that statement. You don't deal with nutters. It's that simple. So how have the current service dilemmas arisen? My starting point is that children and young people with gender-related distress are a very heterogeneous group, i.e., you can't just go, they're all the same, which is, thank goodness. Although that's exactly what external groups like Mermaids, Education Celebrate, you name it, those nutters have been doing in schools. Some may go, she then says, some may go on to develop a stable trans identity. I doubt there's such a thing. And we now know that there is extreme damage post-transition. We know that they find themselves with reduced lifespans, with osteoporosis, all sorts of problems that are being revealed now as we see the first generation of older trans people, A, enter the care system, where if they have dementia, they forget that they have transitioned, and then B, from illnesses that are becoming apparent with people who are detransitioning. So I'm very concerned about that as well. Some may go on to develop a stable trans identity and may benefit from medical intervention. It's not medical. That's my problem with it. It's not medical. It's experimental. Ghoulish, even. Whilst others may resolve their gender-related distress in different ways, many of those presenting to GIDS have complex mental health problems and or neurodiversity and need a holistic package of care. Couldn't agree more. This is what everybody's been saying all along. Helping every young person find the right pathway for them as an individual is an essential role for professionals in the field. Right, early in the review process, we set up a panel of children's healthcare professionals to understand their perspectives on working with this patient population. We fully expected workload to be a barrier for many. Interestingly, although this was flagged as an issue, the greater challenge was the lack of a consistent view about the nature of gender dysphoria. And therefore, the role of assessment for children and young people experiencing gender-related distress. That's better. Although I still think it's just nonsense. Sorry. Some felt that they were expected to take an unquestioning affirmative approach, but did not feel comfortable doing so. That's been the only approach. So you can see here that what CAS has, the CAS review, not CAS, the CAS review, what the CAS review has to do is to work within almost a walled garden. So she's doing exactly what she was asked to do. And that's the walled garden. Yep, working within that walled garden. There was also concern, as again, amongst this group of people they got together who were specialists, there was also concern about the lack of evidence or guidelines to support treatment decisions. I mean, my personal take on this would be that there are no experts. They're only experts in identifying the different categories of people who pretend they're one thing or another. There doesn't seem to be any experts. If there was, I think we wouldn't be in this mess. On a more positive note, sorry, my apologies. There was also concern about the lack of evidence on guidelines to support treatment decisions. For many, the path of least resistance was a direct referral to GIDS. And there you have it. The doctor, whoever it is that's approached by the young person, then saying it's okay, we're going to send you to GIDS, because they had no guidance. They had no idea what was going on. They probably have only heard about the affirmative approach that's being drenched across the NHS and other private providers, so they would have only known about that. But yet something would have felt wrong. They knew it was wrong. On a more positive note, this group of people they got together, many felt that they already had transferable skills to work with this patient group, but they required some specific additional training, support and guidance. So there you go. If you need training, support and guidance, you're not an expert, are you? GIDS was established as a sole specialist provider at a time when there were only about 50 patient referrals a year. Since then, referrals have increased exponentially. The case mix has changed and a single provider is no longer a viable option. NHS England has responded to the recommendations in my interim report by starting an expansion into regional centres. But this will only be successful if we can attract and engage the workforce, both within the regional centres and then in network secondary services. This approach has already worked very well in Finland, but how do we address the anxieties of professionals across the children's healthcare workforce in the UK? Again, here, that walled garden in play. They're only talking about this from a healthcare perspective, when you and I imagine most of the people that are working on this, possibly including Hillary, know damn well the damage is done long before they get to the healthcare system. The iatrogenic nature of it, treating of it in schools, the iatrogenic nature of it on television, the iatrogenic nature of it in documentation, in books, in libraries. We know the harm is a social contagion, but here Hillary must keep within the walled garden of healthcare that she has been asked to investigate. So he then says, firstly, drawing parallels with safeguarding, the fear for any professional is that a wrong diagnosis in either direction, either missing an abused child or wrongly diagnosing abuse, can have catastrophic consequences. This is very true. I don't think there's any diagnosis criteria for this at all. It appears to amount likes boys, girls, and likes girls' clothes at the moment, doesn't it? Or whatever mermaids stick on their stuff that they train people with. At the height of some of the worst safeguarding failures, the evidence and guidance to support decision-making was wholly inadequate. Ain't that the truth? Or it was hopelessly tainted by Americans. Sorry, Americans. But you brought a lot of safeguarding nonsense over that caused huge problems. The confidence of the profession was increased through better research and evidence, followed by a defined training curriculum and clear guidance. We need to do the same for gender identity services for children and young people. I've got a problem with that. We don't. We need to ensure that every doctor and nurse in the land knows it is a made-up fantasy by John Money, and that its spread is the same as a religious cult. That's what they need to know, so that they know from day one that what they are treating is a severe delusion, often seen then as a symptom of a greater malaise that remains hidden until they explore with the child, or that could be easily dispelled by education of those children. There's the rub. And I would say that the education triage, again, Cass, it's healthcare, she's not in that area, but I would say that the education triage could probably be seen to be part of that. Here we go, off you go and listen to this. The research group commissioned by my review is currently conducting a formal review of the evidence underpinning assessment and management, and also has a qualitative and quantitative research program underway. This will help reduce but cannot eliminate uncertainty and risk. To make further progress, we need a national clinical and research network and an ongoing programme of research. I am currently working with NHS England to ensure these are established. NHS England, who are still flying the progress flag. NHS England, much of whom still remain firmly joined at the hip to Stonewall. How can Cass possibly achieve within the confines of the walled garden, unless bringing perhaps some illumination that we can then use to move forward? I have also recommended conducting a prospective research study to fully understand the risks and benefits of treatment with puberty blockers, and this will need careful study, design and attention given to the ethical considerations. Secondly, regardless of the polarised debates playing out in the media, it's not a polarised debate, Hillary, it's right and wrong. A polarised debates playing out in the media, as clinical professionals, but again, she's stuck with the walled garden. As clinical professionals, we must find ways to debate this difficult topic respectfully with curiosity and open minds. There will not be black and white answers. There are black and white answers. Stay away from the kids. That's what these people, before they get to you, Hillary, I mean, you know. We are seeing a generational shift in attitudes to the meaning and mutability of gender. No, we're not. No, we're not. What we're seeing is a mass indoctrination of children and young people by bad actors, bad faith actors, under the rubric of inclusion and critical social justice. That's what's happening. And that's what's missing from this to me, is this recognition of this cult-like thinking, wokeism, all of the things that are attached to that are part of it. However, the question of whether and when to intervene medically in young people who are in a dynamic developmental state is challenging and will not be resolved without thoughtful discussion and the ability to listen to and understand opposing views. Firstly, we have to ensure that professionals feel safe to ask questions in an open, curious and non-directive way, as they would when exploring any other aspect of a young person's thinking and identity without fear of legal challenge. The planned conversion therapy bill needs to provide clarity on what conversion therapy is and what it is not. Again, the implication being gender identity is included in the conversation. It shouldn't be included in the conversation. It's not real. Gender identity is personality. Gender expression is fashion. It is not real. Perhaps Cass cannot currently say that unequivocally for reasons that we do not know. So again, working within multidisciplinary, multi-thoughts, multi-beliefs, multi-ideas. Yep, okay, must be very difficult. So Cass has already raised these points with ministers and officials, so the conversation is taking place. Thank you, Hilary. And we will continue to do so in the coming months. I strongly believe that with more open discussion, research and clinical collaboration, we can transform this topic from one which causes anxiety and controversy to an interesting and rewarding area for clinical innovation and research, and significantly improve the NHS offering to these children and young people. I would like to applaud RC Psych for providing a platform for different views in this issue of Insight, which is the name of the magazine. I want it shut down, but that's just me. Right, get it out of schools, get it out of everywhere, out of nursery schools, get the drag queens out of the drag queens, get the queer performers out of the library, get it gone. Name it, identify it, state it, legislate it out of its existence, and a huge public education campaign. That's what we need. However, a thoughtful, measured piece from Hilary there about the Cass review, and again, I will remind us at this point, within the confines of the walled garden, that the confines of what the actual review is about. So that was the first thing that came out from that article in Insight today that was interesting. This is a long one, so if you want to shut me up and go and get a coffee, feel free, right? Because there's more than one bit to it. Now, we then have two follow-on comments from doctors coming from different sides of the argument, and here's where it gets interesting. The title of this particular piece is called First Do No Harm, which is primum non nocere, which is the Hippocratic Oath, firstly do no harm. Two of our members give their views on providing care for individuals with gender dysphoria. Again, the concept of gender dysphoria there being given much more weight than it needs to have. Now we know that it's simply a symptom. Dr. Eleanor Hines, Consultant General Adult Psychiatrist. And here is what Dr. Eleanor has had to say. As doctors, our job is always to weigh up the possible harms and benefits of intervention and attempt to offer patients informed opinions in order to reduce overall harm to them. The debate around the care of trans people has devolved into unhelpful, sometimes harmful territory. The inflammatory rhetoric used in these debates often detracts from crucial questions. In this case, how can we best provide gender care to children? Well, Dr. Eleanor, the best way to provide gender care for children is not to provide it at all. Okay? The debate around key discussions relate to ethical and philosophical questions around parenting and autonomy, the autonomy of the child. Specifically, at what point a young person with sufficient support can make decisions about their own body. Oh. As a psychiatrist, it is fundamental philosophy that underlies my work to support people to make their own decisions. I'm not comfortable with it either, right? Harm associated with being trans is thought to derive partly from negative social forces and partly from the persistent sense of the trans person's body being misaligned with their gender. Olson found that socially transitioned trans children who are supported in their gender identity have developmentally normal levels of depression, indicating that harm can be mitigated by such approaches. What Dr. Eleanor fails to talk about is the hideous suicide level years later. Trans people of all ages experience discrimination. What's that got to do with it? Either directly or indirectly within society. So do I. What has that got to do with it? Nothing. It's making me think here that this isn't actually a medical response at all. What do you think? Have a look. In response to these cues, trans people learn that it is not desirable, if it is even acceptable, to be themselves. There's no such thing as being yourself based upon a mental condition. If it wasn't a mental condition, you wouldn't be writing this. I identify as an anorexic. Nobody would say it. Such internalized rejection is not unique to gender minorities, but relates to most marginalised groups surrounded by a hostile community or environment. She's talking about me. She's talking about gays and lesbians. We're not the same. Sadly, as medical professionals, we can contribute to this sense of alienation through ignorance or pathologising trans identities. It either is something that requires medical intervention or it's not. I don't know what you mean by that. And we should therefore endeavour to seek suitable training. Within this context of wider discrimination, significantly increased rates of depression, anxiety, self-harm, drug and alcohol use, and suicide occur in the trans community. This has been debunked repeatedly, and there it is again. This idea of suicide ideation, especially when you're talking about children, is a very worrying thing to hear from a psychiatrist, I would say. And I'm not a specialist, but I would imagine there's a competency issue there somewhere. We do not always know at point which medical intervention is the most appropriate in a trans person's life. We do not always know the point at which medical interventions are most appropriate. So the idea is you can have it. A person's life. The evidence we have shows that among adolescents with gender incongruence who receive puberty blockers, the majority experience improved well-being as a result. This is insane. It is vital that our decision-making regarded by best interests of individuals is guided by the best available evidence as to what is most likely to improve well-being on a case-by-case basis. It's got nothing to do with well-being. Nothing. It's got to do with bodily integrity, that which is right. It's got to do with the fact that most of them grow out of it. Most of them are gay and lesbian. Most of them have got autism or ADHD. Some are foster children. Some have been abused in the home. And you simply go, right, here's this one symptom. Let's treat that and alter the body to make it into that of the mind. Absolutely bonkers in my book. What do I know? I'm not a psychiatrist. Sorry, Eleanor. It is vital that our decision-making regarding the best interests of individuals is guided by the best available evidence. You can't even decide which evidence is true and which evidence is false. We know the stuff you're talking about has been debunked. Regarding the best interest of individuals is guided by the best available evidence as to what is most likely to improve well-being on a case-by-case basis. Besides noting gaps in the evidence base, the Cash Review Interim Report calls for equity of access to assessment and treatment and indicates that a new service model is needed. Equity of access? What the hell does that mean? Equity? Really? Ensuring timely and adequate care would enhance... No. I know what you mean by timely. I could have you all wrong, you know. I'm just full of it. I'm a nonsense merchant. Ensuring timely and adequate care will enhance capacity for good decision making and better enable clinicians to weigh up arguments for or against medical interventions as appropriate. There should be no medical interventions in children. None. Not one. Including, sorry Henry, puberty blockers. We know the harm is already there. No, we don't. If specialists delay treatment to young people, many of them will suffer. No, we don't. You know why we don't? And you're quoting somebody from 2022, we don't know. We haven't got the evidence base at all. Equally, if specialists rush treatment or fail to provide necessary opportunities for exploration, many will suffer. Oh, here we go. Gender is not binary. Women and men come in all shapes, with all possible facets of character, as do those who do not identify with or simply fit within those binaries, despite others thinking they should. Gender care is not binary either. It is not medicine or psychology, but medicine and psychology. And psychiatry is well placed to be at the forefront of providing care. I don't think so. Sorry. No, don't think so. I'll let everybody else make up their own mind, but I personally don't think so. But what do I know again? Primarily, we must not fail to treat people with the best available evidence. But the best available evidence is this. Most of them are gay or lesbian, right? They'll grow out of it by puberty. You don't sacrifice children who are well on the altar of children who aren't. So if you want to lower the harm, when you think about it on a societal scale, we end it all. Primarily, we must not fail to treat people with the best available evidence, but at the very least, we must ensure that our avenues in discovering the path of least harm. The path of least harm is that we do not allow it at all. That's the path of least harm, right? Because even if it was, for every 100 trans people that were happy, one gay person was mutilated, I'm not paying that price and nobody should have to. Nothing, right? Trans this, trans that. No. But at the very least, we must ensure that our avenues to discovering the path of least harm through research are not predicated by thoughtless bans on aspects of care driven by prejudiced people. Okay, Dr. Hines, I think you're a critical social justice warrior. That's what I think. And I think that was written from that standpoint. And that's okay. It's okay for you to take that standpoint. And like I said, I'm a bloviating windbag. So you don't have to believe a damn word I said. You know? I'm asking my people who are watching now, my Jesterites and my YouTubers, you go and have a read. Go and have a read. You tell me what you think. Then we get the final one, which again comes under the title First Do No Harm by Dr. Stephen Westgarth, consultant child psychiatrist. We are increasingly asked as clinicians to assess and offer treatment for young people with gender dysphoria. I have much empathy for this group who suffer and feel discriminated against. However, there are many challenges to addressing their suffering. We frequently see patients with a disconnect between their perception and reality. Anorexic patients may consider themselves obese. Phobic patients consider the phobic object to be threatening. Patients with body dysmorphic disorder think their healthy body is in need of surgical change. We never affirm that a person with anorexia is fat, first, because the claim is not true. Second, to do so would likely cause harm. Adolescents with GD present many similar challenges, and we should apply similar principles in treatment. We stand by the fundamental ethical principle of non-maleficence, as captured in the maxim primum non nocere, firstly do no harm. There has been an increase in late presentation of GD in adolescents. That's the social contagion. There's your ROGD, Lisa Lippman, right? Often with comorbidities, here we go, including ASD, self-harm and emotionally unstable personality traits. The sufferer's body is usually unambiguously healthy, and although rarely tested, so is their genotype. Distress arises from incongruence between normal gene expression and self-perceived gender. The body is healthy, but self-recognition and acceptance are disordered. Yet, when young people with GD too often receive affirmation that their dysphoria stems from the wrong socially assigned gender, as though their body were irrelevant, simplistic affirmation of their self-identified gender can be highly problematic. A short-term placation and collusion may generate profound damage on both personal and social levels. Now, this is somebody who knows what they're talking about. The affirmation model is internally inconsistent. On one hand, GD, gender dysphoria, is described as not an illness, and yet medical treatment with hormones and surgery is sought. This inconsistency perhaps reflects the disconnect from reality present in gender dysphoria. Unacceptable delays in care create impatience and distress. Meanwhile, trans support networks coach sufferers to give responses likely to obtain desired physical treatments. Who is it? Ooh, Stephen Westgarth. We like you right now. A September 2021 Cochrane review found even insufficient evidence to support the use of hormone therapy in helping transgender women transition. Similarly, a Cochrane database search I conducted for gender transition, surgery efficacy, sex change, and surgery efficacy revealed no results. Nil point. There is a lack of evidence to support radical surgical and hormonal intervention in children. In a Swedish total population review by Brandstrom and Pachankis in 2019, eventually, after correction, reported no benefit of gender reassignment surgery in relation to mood, anxiety-related healthcare visits, prescribing, or hospitalization from suicide attempts. However, where psychological exploration is used, the results are positive. A substantial, right? Get this, 70 to 95% of gender incongruent young people supported psychologically without the affirmation model returned to being gender congruent with their natal gender, and we've known that since 2011. Too many have leapt to facilitate social transition, puberty blockers, hormones and surgery, despite lack of evidence of efficacy and counter to the probability of ultimate gender congruence. The interim report from the CAS review highlights that even social transition is not a neutral act, but it is an active intervention, and yet this often takes place in schools before any assessment by medical or mental health services. I do not dispute the distress inherent in gender incongruence. However, I do dispute the evidence supports the benefits and ethics of the affirmation model. First, do no harm. I suggest some solutions as follows. Approach GD with empathy, recognise the many influences on our child and adolescent patients, society and ourselves, explore the psychological and social etiology of gender dysphoria in children and adolescents, educate patients and the public that surgical and hormonal treatments for psychological problems lack evidence of efficacy and can cause harm, emphasise that other evidence-based treatments compel us to give psychological treatment, help society understand and resist the simplistic affirmation model, and pursue research in gender dysphoria, etiology, treatment, and long-term outcomes. I love it when I'm right. Well, these are two different views for you to consider. Cass, giving us the current situation, where she stands, what her position is in this walled garden in which they play. Okay, and then two positions there, one from one side, one from the other. I personally think the first one was pure critical social justice, if you read between the lines, but you have a look and let me know what you think. It's also an issue of competency there, I feel. Nothing mentioned about safeguarding or nothing mentioned about what we shouldn't do. So under the rubric of first you do no harm, the second one that I read seems to be the one that will do the harm. And then we have the third one, that I've just finished, which I have to say resonates strongly with me, as this is exactly what I've been advocating for the past 2 years. And many others, not just me, many others as well. So I would say that this is a very interesting occurrence within our current fight. Don't take the foot off the pedal. I've said this already. I said it today, didn't I? Don't take the foot off the pedal. I understand that Hilary Cass and her team are in a very, very distinct position of looking at the healthcare aspects of this. And thankfully, people like Clive keep me on track remembering that. So I'll say something outrageous and Clive will pull me back. So that's good news. And I think that's important to let them finish their job. Let's see the report. But I am still strongly of the opinion, and you can tell me in the Dubries whether you are, that I think it's about time we had a public inquiry. And as Dennis has told me today, the trouble with them is they take so bloody long. Well, I say let's have a moratorium and let's have a public inquiry. Let's halt everything until the public inquiry is finished. At least then we can be sure that we're not damaging any gay, autistic or lesbian children anymore. Because right now I'm not convinced we aren't. We still have to see what Gillian Keegan's going to do in education. We still have to see what's going to happen in the public sector in terms of them pushing this nonsense within the organisations. So we're still going to have to look at all that. What's happening in HE, what's happening in FE, what's happening at sort of primary level and above. So all of these things still need to be looked at. But by reading the third, I'm cautiously optimistic. It's all out there to play for. It's just not known by the public. And that's what we need to do, really. Huge public education campaign. Perhaps I should do lectures in a park. Ladies and gentle beings. Anyway, look, go and have a nice evening. It's not good news and it's not bad news. And all it does really is leave us where we were before. Wait for the rest of the report and we'll see what happens, good peeps. Go well, all right?